very senior dermatologist that we are all very proud of. So I will be introducing her. So today we're having a talk from Professor Adebola Ogunbiyi, a professor of medicine at the College of Medicine, University of Ibadan, and a consultant dermatologist at the University College Hospital Ibadan. Prof has several affiliations and has a lot of certifications attached to her name. She's currently the chairperson of the Faculty of Internal Medicine of the National Postgraduate College of Nigeria. She's the past vice president of the International Society of Dermatology and the immediate past international board member of the American Association of Dermatology. She's also a past president of this beloved association and a vice president of the African Society of Dermatology and Venereology. Her areas of interest are dermoscopy, hair and nail disorders, and disorders of the pilosebaceous gland. I did tell you that Prof has a lot of certifications, so I'm just going to say a few of them. So she's a fellow of the West African College of Physicians and the Postgraduate College of, sorry, I'm mixing that up. She's also a fellow of the Royal College of Physicians, Edinburgh. She's an international fellow of the American Academy of Dermatology, and she is a fellow of the National Postgraduate College of Nigeria. So, Prof, for her talk. So, Prof, thank you very much for accepting to talk to us. And we know for sure, going from her pedigree and past associations, that we are all in for a lot of learning. Thank you, ma'am. So, Prof,
hello. Can you see my screen?
Yes.
Okay. I'd like to thank Dr. Andaba for that extensive presentation. So I'd like to thank everyone. I'd like to start by thanking the NAD for this opportunity to talk about acne, the MAX. And I'd also like to thank our sponsors, Beiersdorf, for sponsoring this presentation. So conflict of interest, yes, I have speaking engagements with Beiersdorf, and this is one of them. So today we're talking about acne complications, and I guess a lot of people are wondering why are we harping on acne, but I guess we all know that one of the complications of acne is one of the reasons why we do have people referred in to the clinics who have been badly managed by quacks outside. So we'll briefly talk about the pathogenesis of acne and that of post-inflammatory hyperpigmentation due to acne, and then the impact on the quality of life. We'll talk about management of PIH, and then we'll mention Thymidol, and then we would end up with a global consensus on management of hyperpigmentation, which I think is a very good one. So we all know what acne is. It's a chronic disorder of the pilosebaceous glands, and is characterized by the presence of comedones, papules, pustules, nodules, and cysts. We might not see patients with extensive acne like we're seeing here, but we all know that it's variable. Now, acne is found on sites where you have sebum production. And one of the problems, I would say, with acne is that it affects the exposed sites, especially the face. And that is why it is one of the disorders that affects the quality of life of our patients. The global burden of the disease, acne is the 8th most common skin disease worldwide, and it's estimated that 9.38% of all groups would have acne at some time. We all know that the prevalence varies among different countries, and it appears that there's an increase in adolescents, and we do not have a recent data, but a lot of people have worked on acne in Nigeria, and it would appear that the rates are increasing. It's believed that every adolescent will go through acne at one time or the other. Now, there's a study by PariFab, which was done 2023, and their own global prevalence was 20.5. It looks at the prevalence in adolescents, and it has 28.3%. For that, in adults, 19.3%. And women tend to have more acne as adults than men. And there seems to be a high prevalence in Latin America and East Asia. Now, whether we like it or not, this acne causes a major impact on the quality of life. It's very interesting when you see parents talk to their teenagers and say, look, what is it? I had this acne, it's going to go. It's not a problem. But we do know that it is a problem. And apart from impacting the quality of life, it also causes stigmatization. Now, briefly, we'll talk about the pathogenesis of acne. We say there are basically four pathogenic factors. So we would have increased sebum production. This is a slide showing the pilosebaceous gland. We have the sebaceous glands emptying into the hair follicle opening. So people with acne tend to have oily faces, increased sebum production. We also know that there's hyperkeratinization of the gland opening. So in other words, the desquamation at the epithelial surface of the opening of the gland is affected, and so it seems to cause a blockage. Now, because of the blockage, we know that you would have sebum accumulating, and then we also have the Propionibacterium acne, now known as Cutibacterium acne, also there, which leads to inflammation. So basically, there's increased sebum production, hyperkeratinization, the Propionibacterium acne, and then the inflammation. However, we also know that there are exogenous factors that can also contribute. So the environment, heat, sweat can also make acne worse. We know that stress affects skin disorders generally. Smoking is also a problem. It can make acne worse. And diet and cosmetics. So with diet, there's a lot of studies going on what kind of food, but I think there's an agreement that food that has high glycemic index that would stimulate insulin, ultimately stimulating androgens, may actually make acne worse. And then we know that hormones to play a part in acne production. So on the B side of the slide, we have the normal pilosebaceous gland, we have the sebaceous gland, and this is depicting what happens. So the early lesions in acne are the comedones. You have the blockage. Where the blockage is not totally complete, you have a blackhead, and where it's complete, you have a whitehead with a distension. At these stages, they look non-inflammatory, although recent studies are showing that even these so-called early lesions may have some inflammatory take to them. And then ultimately, you now have the inflammatory lesions where you have the papules, there's erythema, there's swelling, and then you begin to have pus-like lesions, and then you can have the nodules and the cyst. So how do we treat acne? It's targeted to what I already said: the sebum overproduction, follicular hyperkeratinization, colonization of the Cutibacterium acne, and inflammation. Recently, for sebum overproduction, we know that there's a topical agent called clascoterone, and it's an androgen receptor inhibitor. It's used topically. It's been noted to reduce sebum production, so it actually reduces the oily feel. But that would only be relevant when you have mild comedones. Then we know for the follicular hyperkeratinization, we use various things that are epidermolytic, that would reduce, that would open up the pores. So we have the retinoids, various types. We even have the benzyl peroxide, can be used as anti-inflammatory and can also be desquamating. And then for the Cutibacterium acne, we have both topical and oral antibiotics, which also works for the inflammation. Now, the basic treatment principles, when somebody comes with acne, you want to look at the type. And so you want to treat based on whether it is clinically non-inflammatory or whether it is inflammatory. And then the extent of the lesion would also affect the choice of therapy. So with the non-inflammatory ones, we tend to use a lot of epidermolytic agents, the topical retinoids, benzoyl peroxide, things that can desquamate. Inflammatory ones, you might want to use systemic antibiotics, the doxycycline, tetracycline. We're using them for their anti-inflammatory properties and not necessarily as an antibiotic. And when it's very extensive and you have the nodulocystic acne, then you want to use the retinoids. Now, for the long-term management strategy in acne, skincare is also important. As we say, even for the normal skin, we talk about the adequate skincare. So for acne, for those who are acne prone, it's important that their skincare is looked at, the kind of cleansers they use to make sure that they don't use abrasives, and diet, like we said. Now, the complications of acne are all known to us. And on this, we can see a man that has acne scars. He has the various acne scars, the box scars, ice pick scars. We can even see some pigmentary problems here. And then on this side, we have this lady that has mainly post-inflammatory acne. Interestingly, we all know that a good number of our patients will come in at this stage. They might not have the active acne lesions, but they would say, look, I have this black spots for acne. Now, the other important aspects in terms of complications is the fact that acne affects the quality of life of an individual and that it can be stigmatizing. So we all know that for dermatological disorders, a lot of them do not cause high mortality, but the morbidity is a lot, and it does impair the quality of life of the patient. We're talking mostly about post-inflammatory hyperpigmentation. Post-inflammatory hyperpigmentation is a sequelae of inflammatory skin disorders. So it could be acne, it could be eczema, but acne is what we're talking about today, and that gives post-inflammatory hyperpigmentation. Now, post-inflammatory hyperpigmentation is common in the dark skin. So Fitzpatrick type 4, 5, 6 tend to have post-inflammatory hyperpigmentation, and it results from increased melanin production, or you have abnormal distribution of melanin or the melanosomes after an inflammation has been taking place. Now, it's very important that we address post-inflammatory hyperpigmentation because we all know as dermatologists that this is one of the reasons why we have a lot of our young ladies using skin lightening agents wrongly. And by the time we tend to see them, they're now coming with side effects from use of skin lightening agents. So it's important that we pay attention to post-inflammatory hyperpigmentation. In terms of prevalence, like we said, it's common in those who have acne, it's common in those who have type 4 to type 6, and it's believed that up to between 65 and 80% of acne patients would have post-inflammatory hyperpigmentation. Now, there was a study that in the African Americans that found that 65.3% actually reported post-inflammatory hyperpigmentation as a bothersome part. And we all can relate to this, that a lot of our patients are more worried about the black spots than the active lesions itself. And in the Latinos and Asian populations, it accounts for up to 58%. Now, for the lighter skin tones, they do have post-inflammatory hyperpigmentation, but not as much as those with the darker skin types. So what is the pathogenesis of this acne-induced post-inflammatory hyperpigmentation? So basically, there's increased stimulation of the melanocytes. We all know that the melanocytes are in the basal layer, and you have your melanocytes producing melanosomes. So the melanosomes produce the melanin. So there's a stimulation to more melanin production, and we'll still talk more about that. Or you can actually have the melanin now dropping into the basal layer of the dermis. melanin production does not take place in the dermis. But once there's disruption of the basal layer, you can actually have huge melanin granules dropping into the dermis, and the macrophages hold on to them. We call them melanophages. Now, other possibilities for the stimulation of the melanocytes has been, it's suggested that it's possible it's an innate response to the presence of the Cutibacterium acne. In other words, just having the organisms on the face can actually stimulate melanogenesis. It's also known that we have a lot of prostaglandin derivatives, leukotrienes, cytokines that take part in the inflammation, and these are also believed to stimulate melanogenesis. The roles of toll-like receptors is not clear. People are still looking into them. And then the effect of the skin microbiome is also being looked into. There are studies looking at the skin microbiome and the tendency to having post-inflammatory hyperpigmentation when you have inflammation. Now, melanin itself that is produced in the melanosomes, which are in the epidermis. Melanin is produced from tyrosine. So we have the amino acid tyrosine, and the tyrosinase is the enzyme that converts tyrosine to L-dopa and dopaquinone. And that is the rate-limiting step of melanin production. So at the end of the day, when there's a lack of cysteine, you have eumelanins, which is the brown to black pigment that we have. And for those who have, when there's cysteine, then you can have the pheomelanin, which is the yellow to red. So what happens in post-inflammatory hyperpigmentation is that there's an increase in melanin production because the melanocytes are stimulated to produce melanin. Now, there are points to remember with regards to post-inflammatory hyperpigmentation. The depth of the pigmentation could be strictly epidermal. Like we said, melanogenesis takes place in the epidermis. So you could have excess melanin production in the epidermis alone, and that tends to give light to dark brown discoloration. And because it's in the epidermis, which normally would exfoliate, it tends to resolve faster than what you would have when you have dermal post-inflammatory hyperpigmentation. I said for the dermal post-inflammatory hyperpigmentation, there's disruption of the basal layer. So the melanin granules that have dropped in are held on by the macrophages. And sometimes because of the size of the melanin granules, the macrophages hold the pigments like a tattoo. So it will take some procedure to fragment the melanin granules, or with time, you can get rid of them. And that's why the dermal post-inflammatory hyperpigmentation tends to take years unless you have some procedures. Now, it's also important that the severity and the duration of the inflammation also affects the post-inflammatory hyperpigmentation. And that's one of the reasons we always say it's better to treat acne, eczema, anything that causes post-inflammatory hyperpigmentation early. The sun exposure worsens post-inflammatory hyperpigmentation. We know that ultraviolet light is one of the things that stimulates hyperpigmentation. Now, irritants or trauma can also stimulate post-inflammatory hyperpigmentation, and this is becoming a very important part of concern in our environment. Now that a lot of people are using organic, so-called organic chemicals, you find out that people are using lime, people are using all kinds of scrubs, and this would also increase the post-inflammatory hyperpigmentation. Now, it's been known that just with topical therapy, either treating the acne or starting treatment with post-inflammatory hyperpigmentation, can actually shorten the duration of treatment of the post-inflammatory hyperpigmentation. And then in a few patients, you can actually have the post-inflammatory hyperpigmentation fade without treatment, especially if it is epidermal. But it's also important to know that it can persist for several years, up to 5 years, and some it rarely disappears completely, especially if the inflammation is deep. Now, tools have also been put together and validated to grade post-inflammatory hyperpigmentation. This is important when you're trying to try new dermal cosmetics or treatments. So you can have the post-acne hyperpigmentation index, and you can also have the acne-induced pigmentation gradient. And this is useful when studies are being done. You can actually validate it in this environment, and then we're all saying the same thing. Now, why is acne-induced post-inflammatory hyperpigmentation a source of concern at this time? Like we said, it affects the quality of life of the individual, and it has stigmatizing potentials. As dermatologists, I know we have those who are not dermatologists on here, but you have a lot of patients in the clinic and you have people waiting. So there's a tendency to focus on drug therapy, a bit of counseling. Whereas you have somebody sitting in front of you who does not want to leave the house, who does not want to go to parties. And in the extremes, where you have people that have nodulocystic acne, they might actually be contemplating suicide. Now, skin disorders, we all know in this environment, also have a stigmatizing potential. So there was a study carried out by USERIN, the International Stigmatization Study. And as we can see here, you have different colors, different Fitzpatrick color type. And it said that every fourth person suffers from a skin disease, which is true. Some of them, we say they are normal. Some of them can be quite, what's the word? Can be quite devastating to whoever has it. So based on previous studies done, there's a publication in the British Journal of Dermatology, it shows that skin disorders can be stigmatizing. And we can see the snowstorm here, where you have the difference between people that have a clear skin and people that have post-acne marks. So the study done involved a few countries. Nigeria was also involved. And the study was to look at the perception of patients with acne, to evaluate the perception of acne with post-inflammatory hyperpigmentation, and also to look at the degree of stigmatization in different countries. So we all know that skin is clearly the first thing people notice in the face of an acne patient. And in this environment, we know people don't mind their business. And so it affects the person who has a skin disorder. Now, one of the things they looked at was, what is the first question they asked during the study? What is the first thing you notice in a person's face? So you look at those who have, they show them pictures of people that had post-inflammatory hyperpigmentation and those who did not. And obviously you can see that 67% of them said it was the skin that they looked at. Whereas in those without, people looked at the skin and people looked at the eyes and the hair. I'll still show further things. So that tells you that when you have a blemish on the skin, that's the first thing people tend to see. So the study also involved participants from Nigeria. The gender, you had males, females, equal, and then you had the various ages, so between 18 to 65. So when they were asked about what they felt, and the slide is not actually coming out very well, but people gave all kinds of comments suggesting that they were sorry for those who had the disorders. Some of them actually felt that they did not take their bath appropriately. And it was amazing how people rate those who have skin disorders. So he's suffering from a skin infection as a result of the body lotion he's using. She has pimples. She needs to see a skin therapist so that she will be given advice on how to care for her skin and some creams and soap that she can use. The person has black rash on the face. It could be traces of pimples or skin reactions to cream or soap. I think the person is a growing teenager. And then we have the last one. So the point is that everybody has an opinion when they come in contact with somebody that has a skin disorder. What came to my mind when I saw the young man was that he's a young man with a lot of pimples, acne scars on his face, and properly it affects his self-esteem. Now, this is the details of the first one I showed. So for the Nigeria perception, faces of people that had PIH without PIH, 72% of them saw the skin, whereas it was 24. With those who did not have PIH, they looked at 8% look at the hair and then the eyes. But we see that with those who did not have, 24 was just the skin. You had others looking at their hair and other parts of their body. So message here is that the first thing is that the area where you have the blemish is what is seen. Now, they also looked at social stigmatization, patients with PIH and those without PIH. So the results here, for those who had PIH, they believe that 26% of them were shy compared with those who did not have. They felt 25% were unhealthy compared with those who did not have. 22% were sad compared with those who do not have. Insecure, 18% compared with 10%. Unattractive, 9% versus 1.2%. And as we can see on the other side as well. So it's obvious that having a skin problem, PIH, is actually stigmatizing. So this is important for us as doctors to realize that our patients that we see that tend to have blemishes on the face, this is the perception of the people that see them. And this is one of the reasons why I think their quality of life is affected. So we can see how it affects attraction, health, even intelligence. People looked at it, skin and being sexy, being happy, be creative, success, whether they'll be successful, and then being reliable. So all this just emphasizes the importance of stigmatization and skin disease. So in terms of whether they were happy, 4.7 out of 10 were presumed to be happy, whereas those who had good skin, 5.8, and then 48% consider this person to be satisfied with life, whereas those who did not have. So it's amazing how just looking at the skin, people had inferences. So in terms of even have a future, 94% believe that this person has a promising future ahead of them. One of our colleagues, Akiburo et al., they also did a study looking at the impact of post-inflammatory hyperpigmentation on the qualities in Nigeria, Obafemi Awolowo. And their conclusion was that people that had facial acne, facial hyperpigmentation actually affected the quality of life. And they concluded that beyond medical treatment, dermatologists should routinely be interested in the quality of life and give attention to the treatment of post-inflammatory hyperpigmentation and skin of color. Now, how do we manage patients with acne, management of patients with acne? Like we said, in managing patients with acne, post-inflammatory hyperpigmentation, skincare, we've talked about that. Emphasis on pH-friendly cleanser, that's so important. Early acne control, let's treat inflammation, that is very important. And I think what we're saying is that they should be referred to the dermatologist as soon as possible. There are a lot of people who try to treat these conditions, but the earlier they get to those who know what they're going so that these things are treated, I think it would help. Now, sun protection is very key. I believe NAD sometime will do some study on the skin sunscreens we have in town. Every time I ask a patient for a sunscreen that they're using, I get a name I have never heard before. And there are times you try to look at the sunscreen and it doesn't have the ingredients. But sun protection, broad is important. And you have oil-free for those who have oily skin. And then to avoid trauma, camouflage can also be used. And now reduction in melanin production. So in treating post-inflammatory hyperpigmentation, the whole idea is to reduce the amount of melanin that is being produced by the melanocytes. And we have so many skin lightening agents. This list is not exhaustive. So they can be topical and they can be oral. So the one we're used to that we use and we still use is hydroquinone. 2 to 4%. We all know the limitations of hydroquinone because of the side effects. So there's also azelaic acid, there's kojic acid, there's niacinamide, and then there's licorice extract. So there are many skin lightening agents that one can use in conjunction with management of acne. We also have the topical retinoids that also will be useful in limiting pigmentation. There's tretinoin, adapalene, tazarotene. And then we now have the oral agents, tranexamic acid, which is also very useful. And you could also have a combination therapy. So there are times you can either use the Klicksmann formula or you could actually combine medications depending on the extent of the post-inflammatory hyperpigmentation and whether it is dermal or epidermal. Now, other procedures that are important that I always prefer people to go to a dermatologist who knows what he or she is doing are the chemical peels. And the reason is that if there's too much irritation from some of these procedures, then the person ends up with more post-inflammatory hyperpigmentation. So chemical peels are useful. And we know that for those who have the dermal type of post-inflammatory hyperpigmentation, then the lasers are very useful as they are able to fragment the melanin granules. And they're useful in skin of color, although you have a caution because of post-inflammatory hypopigmentation. Now, there's thiamidol made by Beiersdorf, which is useful in the treatment of post-inflammatory hyperpigmentation. So thiamidol, also known as isobutylamidothioazolyl resorcinol, has been shown to be the most effective human thyrosinase inhibitor, which significantly has greater efficacy than other agents. Most skin lightening agents inhibit tyrosinase. Now, there's the issue of whether they are all able to inhibit tyrosinase or they compete with tyrosinase. But thiamidol has been found to be one of the most effective human tyrosinase inhibitors. It offers a strong safety profile compared to hydroquinone. And the beauty of it is that once you stop treatment, the melanocyte activity returns. The other interesting thing about thiamidol when you use it is that it does not cause a peripheral hypopigmentation that you would have with others. Now, like I said, the mode of action of thiamidol, it increases, for hyperpigmentation, we know we have an increase in synthesis of melanin due to the inflammation. And the enzyme that does this is tyrosinase. So one of the things thiamidol does, it's able to inhibit the effect of tyrosinase, which gradually reduces the hyperpigmentation. So we can see this first slide. You have the hyperpigmentation, you have the melanin granules. They have been dispersed widely. And once you start your thiamidol, it reduces the amount of melanin that is being produced. So you end up having a more even skin. And studies have been done on thiamidol in terms of pigmentary. I'm looking for appropriate hypopigmenting agents. Bisdorf has done quite a lot of work, we can see, and they have about 120 plus clinical trials, more than 30 peer-reviewed publications. So thiamidol has been proven to be effective for facial hyperpigmentation, post-inflammatory hyperpigmentation, age spots, periorbital hyperpigmentation, body hyperpigmentation. You can use it with laser treatment to reduce the post-inflammatory hyperpigmentation and also to actually prevent it. And it's safe in all phototypes. For those who are interested, there's a lot of literature on the efficacy of thiamidol. It's been compared with hydroquinone cream for melasma. It's been compared with niacinamide. So there are a lot of peer-reviewed journal articles that one can go through to verify the claims for thiamidol. Now, I'll be ending with the global consensus on hyperpigmentation, which took place at the last EADV, and we can see those involved. So we see that you have a wide spectrum. We also have Professor Dolova and Koza as part of them. Now, it was obvious that we needed a consensus on the management of hyperpigmentation. So we have this as global consensus on the management of melanin hyperpigmentation disorders. It's in press with the Journal of the European Academy of Dermatovenerology. So the pigmenting disorders that were looked at that were relevant, sunburn, melasma, I would say for us, you have hyperpigmentary chronic photodamage, freckles, post-inflammatory hyperpigmentation, very relevant. Acquired dermal macular hyperpigmentation, more in acne, is relevant. And then hyperpigmentation of the folds. Now, the consensus in the management of post-inflammatory hyperpigmentation, like we said, you reduce inflammation, you do photoprotection, and then you lighten the hyperpigmented skin. Now, these are the recommendations for from the consensus. Topical treatment is considered as first line, and you have a list of them: thiamidol, azelaic acid, topical retinoids, hydroquinone, tranexamic acid. And then for the non-acne post-inflammatory hyperpigmentation, you also have the list coming on. And procedural-based therapies can be used with care, but they are not first line. And in this environment, we always do first line with topicals. And then in certain situations, you can use oral tranexamic acid, but it said that more data is needed. Now, you have some footnotes here. You need to avoid irritants, especially retinoids in patients who you want to perform procedures on, and then skin priming with lightening agents. Now, they also looked at hyperpigmentation of the folds, this is a patient's armpit. This is something we tend to see. It's commoner in the darker skin tones. The pathophysiology is unclear. It's been suggested that it might be some post-inflammatory hyperpigmentation. And of course, you need to rule out acanthosis nigricans and erythrasma. There are times you might need to do patch testing just to be sure it's not a deodorant or something the patient is using. So the consensus also suggests topical agents: thiamidol, niacinamide, topical retinoids, hydroquinone, desonide, that's a steroid, glycolic acid. And you can have procedures, superficial peelings, you can have Nd:YAG laser being used, and then avoid irritants and allergens, and avoidance of trauma producing procedures like waxing and tweezing. Now, periorbital hyperpigmentation is also something that is common in our environment. People know it as periorbital melanosis, dark circles, infraorbital melanosis, and idiopathic chronic hyperpigmentation of the orbital region. It affects the upper and lower limbs, usually more pronounced. At times it's familial, and some have suggested it might be a form first of atopic dermatitis. We need to work on it in this environment to be sure what it is. And then you have a familial component as well, more frequent in females. And then the pathogenesis, like I said, is not clear, it's complex. So the consensus, they've talked about it divided into four: the constitutional type, post-inflammatory, vascular, shadow effect, with different ways of trying to round up, with different ways of deciding what you're dealing with. The dermoscope has also been found to help in deciding which one you're dealing with. So the consensus has also come up with this recommendation for the four types, whether it's constitutional, post-inflammatory, vascular, and shadow effect. So for the constitutional, azelaic acid, thiamidol, and then you have the procedures for post-inflammatory: azelaic acid, vitamin C, thiamidol, arbutin, hydroquinone, polyphenols, niacinamide, and we should never forget the place of camouflage. So chemical peels can also be used. I would say one has to be very careful if you want to do that around the eyes. Now, the consensus has concluded the call to action in terms of hyperpigmentation is that there's a need for accurate diagnosis and patient-centered treatment approach, which I think that's the way to go. They've also concluded that it's important for us to look at the impact on quality of life. So anytime we are treating patients that have post-inflammatory hyperpigmentation, as although we're quick and we want to write the medications, we need to talk to them about it. Have an idea of how it's affecting the quality of life. And if we think that they actually need more counseling, then you need to do that. And the consensus has come, I mean, they've for those of us that work in this environment, I think is a welcomed summary. And I think it's just for us to do more work on it. So in conclusion, prevention and management of acne-induced post-inflammatory hyperpigmentation is very important. In managing patients with PIH, we need to begin to look at how it affects their quality of life, and their psychosocial state should be evaluated. Now, appropriate, effective, and individualized management should be considered. So we talk about personalized care for acne and acne post-inflammatory hyperpigmentation. Safe depigmenting agents should be used. And where it is necessary, counseling and appropriate support should be given. I'd like to thank everyone for listening. Thank you, my chair, Dr. Annaba. I'm done.
Uh, Thank you very much, Prof. I did tell you all at the onset that Prof was going to give us a very detailed lecture, and I'm sure that we can all agree with that. We've learned quite a lot. So I'd like to do a summary of what she's presented to us. So typically, we've talked about acne and the resultant marks or complications. And I think majority of people here are dermatologists, and we tend to see this patient. A lot of the time, they are not even interested in the acne anymore. They're interested in the residual pigmentation or the marks that have been left. Prof has taken us through epidemiology of acne and also the epidemiology of the post-inflammatory hyperpigmentation that occurs with acne. We've gone through the pathogenesis of acne and also the pathogenesis of the post-inflammatory hyperpigmentation. And we've gone through treatment for acne and also treatment for post-inflammatory hyperpigmentation. But very important is actually the quality of life of patients who have acne and then those who have acne with the post-inflammatory hyperpigmentation. And we've learned today that quality of life seems to be worse or poorer in those who have acne-induced post-inflammatory hyperpigmentation. We've talked about stigmatization with various studies being done, and also even the perception of people who see perception of individuals when they are seen to have acne. And we've looked at studies. Prof has told us about studies which actually showed that once you have a blemish on the skin, that's what stands out. And that's what people notice. They don't even see you anymore. They see just that blemish, which also drives the need for our patients wanting to be treated. They don't want this blemish on their skin. And this leads them sometimes to the wrong places to have treatment. And she's emphasized the role of dermatologists and the need for early attendance by a dermatologist so that appropriate treatment can be done. She's also taken us through various therapies for post-inflammatory hyperpigmentation treatment and also ended up with giving us the global consensus now on treatment. So what's been advocated right now is that once people have acne, especially with PIH, there should be one early treatment of that acne because one of the things that drives the PIH is actually the inflammation from the acne. So there should be early treatment of the acne. Treatment should be individualized. Treatment should be based on the lesions that you're seeing. So the treatment for inflammatory acne will be different from the treatment for non-inflammatory acne. And then for the PIH itself, so we've dealt with treating the inflammation, which is the acne. So you talk about sun protection, and then you also talk about use of lightening agents. And now we have a new kid on the block. We have a lot of lightning agents that we've been using. So we have a new kid on the block, and that's Tamidor. Also, we've talked. She's told us about procedures because when she was talking about PIH, she did tell us that there will be epidermal component and dermal component. For the epidermal component, chemical pills will work, topical agents will work, but once you get to the dermal component, you now need procedures. But there's also been an emphasis now, procedure is not your first line of treatment. The first line of treatment for acne-induced PIH is topicals, Following that, you can now add procedures. So we want to say thank you very much to Prof for this very erudite lecture and very enlightening. Now, before we take questions for Prof, from Prof, I'd like to quickly introduce somebody who will be giving us a 7-minute talk, and after that, we'll take questions because we're going. So I'd like to introduce, just a moment, please. I'd like to introduce Mr. Wilson Opani. That's the medical manager for Beiersdorf in Central, East, and West Africa. So he'll be giving us a 7-minute presentation. And we would like to thank him and Eucerin for being sponsors of this webinar. So Mr. Opani, you are on the clock.
Thank you so much, Dr. Naba. And it's a great pleasure and a great honor to speak right after two persons that I hold so dear to my heart. Thank you, Professor Gumbi, and thank you, Dr. Naba, for moderating this session. I'm not going to take time. Prof has done a fantastic job, and I'm just here to show us the fantastic solutions we have for acne PIH. Prof highlighted the importance of using cleansers that are not harsh on the skin. So we have our cleansing gel, which contains 6% amphoteric surfactants, as well as salicylic acid and citric acid, offers gentle cleansing on the skin. We have our triple effect serum, which contains thiamidol, as Dr. Naba mentioned, the latest kid in the block. But as some people would say, small but mighty. I mean, with over, in just about 5 years, about 10 years of discovery, we'll have a barrage of clinical trials, about 120 clinical trials, 30 peer-reviewed journals, and then over 9,000 patients that have participated in the clinical trial. So we'll have a repertoire of data to validate the efficacy and safety of thiamidol. So these also contained in our triple effect serum, which together with salicylic acid and liposarcon A is able to address the post-inflammatory hyperpigmentation. First, speaking about the liposarcon A that is contained in it, it is one of the signature ingredients of Beiersdorf. Is an excellent anti-inflammatory agent that also has very good antioxidant activity, helping to address the inflammations as well as reducing the impact of sun by mopping up the free radicals that also accelerate hyperpigmentation. And lastly, we have our oil control sun protection, which contains the same liposarcon A as well, in addition to glycetinic acid, as well as L-carnitine technology that addresses the increased sebum production. So these three combo are our basic routine for managing of post-acne marks. Just like it's customary to us, we have clinical trials for every of our formulation. There is always clinical trial to back up and validate their effectiveness and usefulness for the respective disease conditions. We've also had some trials, and I'll just highlight this particular one, speaking on the three major benefits of our triple effect serum and basically our anti acne PIH solution. So first is the anti-mark solution, which is driven majorly by thiamidol. However, thiamidol doesn't work in isolation. Together with the salicylic acid that is contained, which has obviously keratolytic benefit, it's able to enhance the penetration of the thiamidol through the skin and improves its activity on the affected melanated site. And this can produce 80% reduction of the post-acne marks within a period of about 12 weeks, right? Then moving on to the anti-blemish, we talked about it extensively and Prof highlighted, and we can see that for the anti-blemish, we also have significant improvement in the blemish in a period of about 8 weeks, looking at this. So together with the liquor alcohol aid that addresses the inflammation and of course the oxidative stress or activities of the free radicals, we could have improved result with respect to the blemishes. In addition, Prof also highlighted the role of bacteria in the development of these post-acne marks. With our solution as well, you could see that the activity of the C. acnes, right, is also significantly reduced up to 99% within this period. So this just tells us that for our acne ranges, you're certainly going to have anti-mark, you have anti-blemish, as well as anti-shine activity. For the anti-shine activity, it speaks to the oil control technology, which based on patient feedback, 86% of them confirm immediate anti-shine effect, and 93% of them confirm that the solution gives the skin a long-lasting, dry and matte finishing, right? So this together summarizes what our solution for acne PIH can give. One is the anti-mark, two is the anti-blemish, and three is the anti-shine benefit. And lastly, Prof emphasized on the importance of the quality of life. And the global consensus on hyperpigmentation also emphasized the importance of the quality of life, or assessing the quality of life of the patient, or paying attention to the quality of life of these patients who have acne. In Prof's discussion, she also highlighted that majority of the people who suffer from this acne are younger generation, and particularly the Gen Zs, right, who are now at the peak of their life. They have this, and most of them will always struggle with even depression, right? And I'm sure for you who are constantly in practice, these are things you see a lot of the time. Depression is real for them, and the slightest thing they're talking about how the thing is affecting their mental health, right? So, but with our solution, we are able to, you see that 9 out of 10 patients confirmed improved quality of life following from the use of our acne solutions. And for us, our social mission particularly has to deal with this issue of stigmatization, to see how we drive inclusivity. That people have post-acne marks doesn't mean that they should be excluded from the community or they should start living poor quality life. No, and that is why our solutions are targeted at solving these real life problems. And I'm confident that with the discussions we've had, following from the global consensus on hyperpigmentation, Prof's extensive discussion, and these solutions we have, we'll be able to impact more patients and help more patients get over the challenges they have with dealing with their post-acne marks. Thank you for your rapt attention, and I'll be expecting, should there be questions or comments or concerns, I would also be excited to address them. Thank you so much.
Thank you very much, Mr. Wilson Okbani, for that talk. Now we go to our questions. So I'll start with the questions on the chat, then we can ask other questions. So, Prof, you have a few questions. Somebody's asking, what is the place for, I think they want to say microdermabrasion and microneedling in PIH. What's the place for microdermabrasion and microneedling in PIH? That's the first question. Do you want me to read out all the questions
No.
first?
So I think I've seen some, I've answered some, but I can respond to make it easier for you, unless you want to read and then I'll answer. But for
No,
the
okay, so if
micro,
I read it so you can go ahead.
okay, so for the microdermabrasion, it's not going to be a primary reason to use it in PIH. Usually you would use it for acne scars. So if you have somebody that has acne scars, yes, microneedling comes in. And it's believed that once you are handling the scars, then you tend to get some response to the PIH. But the truth of it is that as you're doing the microneedling, you're also using skin lightener, sunscreen to reduce post-inflammatory hyperpigmentation. So it won't be a primary reason to do microdermabrasion. You want me to go to the second one?
Yes, ma'am.
Okay, somebody talked about treatment of post hyperpigmentation in pregnancy. So
No,
what I
no, no, you missed one. The one before
okay,
that
so
says, please comment on the role of COC. I don't know what COC is.
I don't know what
I don't know
COC,
if
so that's why I've left COC. I
that's
don't
why
know what
I don't know what COC is. I don't know if you want to say oral contraceptives or what. I don't know. Okay.
if it's under contraceptives, there's a place for oral contraceptives we know with acne,
I, I don't know what
especially with adult female acne, but I wasn't sure. Sorry, the second one was
Steve, somebody's asking about salicylic acid being useful in
sebum.
management of acne, especially in sebum cleansing.
Yeah, I think it was already just mentioned now in the triple serum of Thiamidol, but we do use salicylic acid both as a wash and you can use it as primary treatment, especially when people have comedogenic acne, because it tends to help the desquamation of the hyperkeratinization at the opening of the gland. So yes, there's a place for salicylic acid, both as a wash and treatment. Then
The one about pregnancy, mode of AI. So acne-induced PIH treatment in
in
pregnancy.
pregnancy. So personally, what I always do is if I can avoid it, I try and avoid it. Not because it can be dangerous, I would explain, but I don't want a situation where you start something and then there are issues with the pregnancy. But it's been known that with PIH in pregnancy, things like vitamin C, both topically and orally, are safe and they can be useful. Niacinamide also can be useful. Wilson has told us that Thiamidol can also be used in pregnancy, and there are many studies available. And the pregnant person should also use sunscreens. So yes, vitamin C, niacinamide, Thiamidol, azelaic acid, I think they're both safe in pregnancy.
Somebody is asking role of doxycycline and retin A cream for acne treatment.
For acne, so doxycycline is still useful for acne. We do use doxycycline for inflammation, but one of the things that doxycycline can be photosensitizing. So if you're going to put anybody ideally on doxycycline, the person should be using a sunscreen. So the chances of just using doxycycline alone without a sunscreen may also improve the sensitivity to the sun. So there's a place for doxycycline. The second one was doxycycline and sorry dear, I can't
Sorry,
see the
and retin A. So the person
retin-A.
retin A in the treatment of acne.
So we still use retin-A. When retin-A tretinoin came
Yeah.
out, it was a block on the kid, and we tend to use it for post-inflammatory hyperpigmentation. That was one of the indications for it. So there's still a place for it. It's just that there are more direct working agents now in terms of inhibiting thyrosinase. So with the tretinoin, they are able
No,
to
no, no. So
reduce.
the person is asking in acne treatment, not even for PIH.
Oh, okay. No, no,
On
no.
role
It's
of
useful.
cycling
It's
and
useful.
retin A cream for acne
Oh, we still
treatment.
use it. Sorry, we still use it. I didn't dwell on acne therapy, on acne treatment. I just went through it. So it's very useful. If I have somebody that has papular lesions in acne, I will do doxycycline. Depending, it's personalized. So there's sometimes you do doxycycline, there's sometimes you will do tretinoin. So both of them are very useful. It's just for us to remember that both of them can cause, doxycycline can be photosensitizing, and then the retin-A can be irritable. Can cause irritation of the skin. So you want to be careful. So we use them.
Someone is asking use natural remedies, turmeric, aloe vera in the management of PIH and if they are scientifically proven.
So I think I'm going to leave that question to Dr. Anna, but what I'm going to say,
Why me? But
what I'm going to say is that with this wave of natural, I think we need to be careful. I am not saying they do not work, but I do not have the experience. Some literature have suggested that turmeric may be useful, but honestly, I think we need more studies. Some of these natural things, lime and things like that, they're also photosensitizing and they actually cause hyperpigmentation. I've heard people talk about aloe vera. So even if they work, the results they're more of anecdotal. I think it's left for us to now do proper studies. We have tools that can grade the pigmentation. And if we have volunteers, then we can use all these things. But currently, I do not prescribe them because I do not know the strength of the evidence. I don't know whether Dr. Anaba has anything to add.
Um, well, aloe vera has a moisturizing effect, but it will not be primarily used for PIH treatment. So just like you said, no. And as to turmeric, turmeric also will be photosensitizing. These things will not, we don't have scientific data for them. And these are things that people use at home. And then sometimes they come to the clinic, they tell you that they've used this and it has cost them more PIH or cost them irritation of the skin. So I think I will not be going with that. So we should leave it as a home remedy and not something we should recommend that people use. And the person who said the thing about COC is a combined oral contraceptive.
Yes, there's also a place for combined oral contraceptive. So, like we said, acne is now personalized care. The patient comes in, you take a history. There's so many things you're looking for. Um, Females, they give a history, is worsened by their periods, or you have somebody that has a history of PCOS. So, yes, there's a place for um, combined oral contraceptives. But it's for us to realize that these things are also combined in management. I'm not just going to leave you an oral contraceptive and not treat other things. You might still need to treat the post-inflammatory hyperpigmentation. You might still need to use a sunscreen. But indeed, yes, there's a place for it.
Well,
Thank
the
you.
other question, I think, between you and Lucy, you already answered that. Somebody's asking if you can use Tamidol for PIH alone, and you already said no. So it can be alone. It's a combination therapy. And somebody that can Tamidol be used as a general skin lightening agent.
Um, Wilson, I think I'll leave that to you.
Okay.
So this talk not about skin lightening. This is a forum of dermatology. Nobody here will be teaching you about skin lightening. We are discussing
Thank you.
targeted and focused treatment of something. So dark spots from a particular disease. So this time around from acne or from other things. So you are not here going to listen to general lightening of the skin. This is not a forum for that. And Tamidol is not for that. Or we'll say, is that what you're marketing Tamidol for?
Thank you, Dr. Anaba. You've addressed it already.
Ah,
We are solving real-time clinical problems. So it's not lightning that we are talking about. So
so
it's purely for addressing acne PIH. I also wanted to just quickly mention something. Yes, thiamidol could be used alone in addressing acne PIH. However, to optimize benefit, that is why the formulation we have has salicylic acid because of its keratolytic benefit and other surrounding pathophysiology of acne PIH. Thank you.
so we've seen there's a question for you. How available are these your triple action solution in the north? So that's for you, we've seen.
Okay, so I will just, I know my colleagues are on the call as well. So I'll quickly confirm the contact of the person, or I'll drop my contact on the call, right?
I
So
think
just
so.
drop me your number. It's very available anywhere we are in Nigeria. We work with a distributor that has connection across Nigeria, and we are very deliberate in our choice. So you can get our range of products anywhere you want it in Nigeria. So I'll just drop my number on the platform so you can just reach out to me and then I'll connect you to someone I'll direct someone to follow up with you. Thank you.
Um, so now, question for you, Prof. The question has to do with suicide. Do we need to involve, and so because you talked about stigmatization, depression, suicidal ideas in people who have acne-induced PIH, somebody's asking, do we need to involve mental health specialists in the management of
Yeah,
this
so
patient?
So what we said is ideally somebody comes in with acne. We'll take a history. Now, we realize that quality of life can be impaired. So you have a discussion with the person. Now, based on the responses you have, you might need to refer either to a psychologist or to a psychiatrist. So I would say yes. And then we know that for acne in particular, you're going to use things like isotretinoin, Roaccutane. They also have the possibility of causing more suicidal tendencies, although one is not too sure which is which. So yes, there's a place, but it will be individualized. So if you come in, I look at your post-inflammatory hyperpigmentation, we have a talk. There are actually tools for assessing quality of life impairment. And you think there's a problem, ideally the person should be referred. Thank you.
Thank you, ma'am. And somebody's asking, is there any risk for the use of hydroquinone for PIH, or is it still safe to use?
So hydroquinone we still use. Now, one of the things about hydroquinone is what do I say?
Profile.
Yes. So you have to be very careful with hydroquinone, and you don't want to end up having exogenous endocrinosis. So there's still a place for it. But what we are now saying is that there are newer the dermocosmetics that are available, that their safety profile are safer and you can handle it. So you will still have some people who want to use hydroquinone, but what we're now saying is that since there are other things you can use where the safety profile is okay, the person doesn't end up with exogenous endocrinosis. Because one of the things we have in this environment is that when you prescribe something for a patient, the patient doesn't want to come and pay a consultation all the time, and the patient just continues on what you're using. So those safety profiles are part of the things you're thinking about. So it's not that it's not totally out of place, like you see from the global consensus. It still has it still has a role to play. It's just that now that we have other things, we might want to use them. Thank you.
All right, so there's a concern by somebody that can we please not use the term triple action with reference to Tamidor treatment? That's actually quite valid, because when we talk about triple action, we're talking about those steroid-based creams. So there has to be another phrase for you to use Wilson. Otherwise, you end up with people instead of looking for a Tamidor and serum, they'll find themselves getting something else. So triple effect.
Certainly.
So somebody has said triple effect. So I don't know how you want to coin that, because triple action is a completely different thing. Okay.
Thank you.
So I think we have the other question you people already answered, and that's somebody asking if we can use Tamidor for PIH on the back, chest, and non-facial sites, and the answer is yes. That's been discussed. So thank you, everyone. We've come to the end of our questions and the end of this presentation. It's been a very interesting and educative one. So thank you once more, Professor Kumbi. We are always proud of you and proud to have you with us. And thank you, Mr. Wilson Opani. Thank you, everyone, for being here. And it was very well attended. So we are very happy with that. Have a blessed evening, everyone.
Thank you.
For now, I do not.
Thanks,
I won't be that
Sue is telling us
we are
about
calling it
physics
medical
now.
physics. It goes beyond
Dr.
what we
Akikugbe
have.
or Hawa?
There's a bit infrastructure.
I don't know, he's telling us about
intensive
physics, but we've
also.
ended. So
The
I think you
same
need
thing
to
also
end.
with medicinal chemistry.
Well, somebody is talking on the background.
Yeah.
It's an
We've come
error,
to
please. So
the end.
just mute the person and move on. An error,
We've come
sorry.
to the end of the presentation. So the secretary needs to close the session. So that's Dr. Hawa or Dr. Akinkube who is attending to us.
Dr. Onodubu
Okay.
will be the one
Yes.
to do
Dr.
closing.
Okay. Yeah. Hello, everybody. Thank you, everybody, for attending this session. We want to thank Prof. Mao. Thank you so much for the very insightful lecture. Dr. Anaba, thank you so much for the very skillful moderation. And we want to thank you, Serene, once again. And this will be the second presentation that they are sponsoring this year. And they still have one more. And we want to remind us that we'll have yet another NAD webinar at the end of this month, last Thursday of October. I think that should be 30th or 31st. No, so should last Thursday of the month. So we meet every last Thursday of the month on Zoom. And we also have our YouTube link that others can join. So thank you once again, and enjoy the rest of your day.
Thank you.
Thank you.
Thank you.